Good evening. Welcome to SpectraCell's Thursday night webinar program. Tonight we bring you Ask an Expert. Dr. Berndard Zenker will be answering your questions. You can submit your questions in the Q&A box on the left of your screen. We will try our best to answer all of them. Let's get started. Welcome, Dr. Zenker.
Hello. Thank you. Thank you, Jessica. Thank you for inviting me. So I see a question here, Jessica. Is this the first one?
Yes, it is.
Okay. So someone has submitted a question. What should I think about when vitamin B12 is low on a micronutrient test, even though someone is taking a multivitamin that contains a good amount of vitamin B12? This is a topic that comes up many, many times in our consultation service, and at face value, it would seem that a patient would be having more than adequate enough B12, and yet intracellularly it is registering low. The very first thing that I think about when I see that is the question, number one, are they vegetarian or not? Vegetarians tend to not have as much vitamin B12. You can have adequate B12 with good probiotics in the GI tract, but over time, if probiotics are compromised, then that vitamin B12 can become a problem and can become deficient. So that's the first question I always ask. If someone is taking B12 and or eating animal protein, particularly red meat, then we would expect that vitamin B12 would be more than adequate. However, if it's low on the SpectraCell test, then that makes me question what's going on with their absorption capacity. And that absorption of vitamin B12, as we know, is dependent upon intrinsic factor. So my next question would be, what's going on with absorption with their GI tract? Are they absorbing it? And the number one guilty culprit as to why individuals cannot absorb vitamin B12 from their GI tract is an infection in their stomach known as Helicobacter pylori. I always ask if, number one, are they vegetarian? Number two, have we tested for Helicobacter pylori? And then number three, have you done a serum B12? Frequently, if I see a really low B12 on a micronutrient test, I will test a serum B12, and I have about 10 or 12 patients where that serum B12 is sky high. What that's telling me is that a patient has high serum B12, yet low intracellular B12. That is suggestive that it's not getting inside the cell where it's so needed for that folate pathway and the methionine pathway in order to go on and make SAMe, for example. And Dr. Yasko, Amy Yasko, has suggested in her research and her work that the essential trace mineral that is needed to enable the transport from vitamin B12 from the serum to inside the cell is lithium. Now, the food that lithium is most prevalent in, if someone is eating it, are tomatoes and potatoes, but only if the soil that those foods are grown in are rich in lithium content. Most of our soil is devoid of good minerals in the United States, unless they're grown in richly organic soil. And so I would suggest clinicians to look at the webinar that's on the web. It's free of charge. Dr. Yasko presents her research in a webinar entitled The Lithium Connection. In the Lithium Connection, she suggests that lithium is needed to transport vitamin B12 from the serum to intracellularly, and actually it's the lithium that enables the release of cobalt. That's the key from cobalamin. Cobalamin is B12. And so those are some of the things that I'm thinking about when I see a really low B12 even though we have trustworthy patients that are taking B12, you think about infection gobbling up that B12, such as Helicobacter pylori. There may be even some other ones, perhaps Blastocystis hominis, or an overabundance of Candida and yeast. But definitely there is research to substantiate that Helicobacter can do this. So you always want to check. I've had several patients where that B12 has been very, very low. I've checked Helicobacter, and then it's come back positive. You get rid of the Helicobacter, and the B12 comes up, and it does beautifully. So I hope that answers questions. If anyone has questions, please post them, and we'll try to get to them through this hour. So the next question I see here is, what are the most important analytes on the micronutrient test to be considered in a patient who has fatigue? So fatigue, there are several things that I look at. As we know, energy, or adenosine triphosphate, ATP, is formed by the mitochondria in the body in the electron transport chain. And so in the back of my mind, I'm constantly thinking about those nutrients that are needed to put NADH, FADH into the electron transport chain from our proteins, fats, and carbohydrates. Now, right off the bat, the number one chief nutrient I always look at is CoQ10. We know that by the time someone is 50 years old, that a person's ability to metabolize enough CoQ10 is about 50% what their ability was when they were 20 years old. So we need CoQ10 to be considered initially. I always look at that, and especially if anybody is on a medication. The most famous of these medications, of course, are the statin medications for lowering cholesterol. Statins inhibit the formation of coenzyme A, which feeds into the citric acid cycle, which goes into the carboxylic Krebs cycle, and then into the electron transport chain. So if you have a patient that's on a statin, I always would suggest you have to put them on some CoQ10 to try to compensate. But it's not just statin medications. It's also many, many other prescription medications, such as antihypertensive medications. And SpectraCell has a really nice printout on their website for clinicians of drugs that interfere with different analytes and metabolites in the body. And what we know is that, like proton pump inhibitor, ACE inhibitors and calcium channel blockers are thought to also implicate CoQ10. I've heard some integrative pharmacologists suggest that for every one dose of a medication, an individual should be consuming 100 milligrams of CoQ10 per day, and that there is no upper limit of the amount of CoQ10 that an individual can take. So CoQ10 is the number one item, but interestingly, we always think about biotin being the nutrient that is needed for skin, hair, and nails. Well, biotin is needed to begin to enable the carboxylic enzymes to work in the citric acid cycle, and so and that's where the proteins, carbohydrates, and lipids are metabolized into CoA. So we have to have biotin just to get the process of metabolism working. For metabolizing lipids, you have to have carnitine and magnesium. Those are both on the micronutrient test, so I always take a look at that, especially if someone's been trying to lose weight and they just run up against a brick wall. And for carbohydrate metabolism, I always ask about, I'm always looking at their alpha lipoic acid. Lipoic acid, B1, B2, and B3 are required for the metabolism of carbohydrates. And for proteins, we know zinc. So you put all of those together, And those are the nutrients we need to help our mitochondria to function and to churn out ATP. But don't forget about the lipid membrane of the mitochondria and of the cellular membrane. And for that, I'm always looking at choline. If choline is impaired, I know that lipid membrane of the organelles, the mitochondria, are going to be impacted, as well as the cell membrane, and the electrical potentials will not be able to transfer as easily. So those are the main things I think about fatigue: CoQ10, choline, as in phosphatidylcholine, carnitine, and lipoic acid, in addition to our regular vitamins and minerals. If someone passes all of that and they're still having overwhelming fatigue, I would encourage them to look at the type of vitamin B12 that they're taking, and I would encourage them to take at least maybe every other day or 50% of their intake of B12 to give a trial of adeno B12, adenylyl B12. The adeno B12 is the type of B12 that is needed to allow the mitochondria to function. So it could be that there's a genetic mutation and they're just not getting enough adenylyl B12 conversion. So I hope that those are some of the different considerations that we can be thinking about for maximizing fatigue. The one last thing I would say about fatigue is don't forget about zinc. If zinc is low, zinc is needed in over 350 molecular interactions in the body, and many of them involve metabolism and energy production. So if zinc is low, that's also going to be implicated with energy production. So I hope that that's helped whoever asked that question. So now, here's another question. A patient who tests abnormal on fructose sensitivity and normal glucose insulin. She does not eat refined processed food, not sugar, only 1 apple a day. The question is, what other non-diet cause of fructose sensitivity could produce this problem? What nutrients can help? Can fructose sensitivity problem affect hemoglobin A1C? Well, here we're getting into the metabolism of blood sugar and the predisposition for type 2 diabetes. In the face of someone eats a clean diet, they're not a sugar alcoholic and they're only eating 1 apple a day, what could be influencing this fructose sensitivity? And could it be affecting hemoglobin A1C? Here's what I frequently think about, and that is the patient acidotic? The pH of the individual. Are they acidic or are they alkaline? And someone may have really cleaned up their diet and done really well with getting rid of sugar, but if their pH is acidotic, that's putting a stress at the cellular level in ways that we usually don't think about. And what I've seen clinically is that can implicate this fructose sensitivity problem in individuals. And what I would really suggest is in a situation like this, I would suggest obtaining the new cardiometabolic report. The new cardiometabolic report has the HOMA-IR, which is a measure, it's a calculated measure that SpectraCell has put together of measuring the insulin resistance at the cellular level. And so it's all of these different factors rolled into one that we have to be considering. And if someone is acidotic, it can inhibit glucose interaction and complicate fructose sensitivity perhaps in other directions as well. So I would look at that. The question is, what nutrients can help with this? I think the major nutrient is trying to do things in the diet and in the body to make sure that a person would stay alkaline. And in that alkaline state, individuals will detoxify toxins more efficiently. We're beginning to understand somewhat more of how environmental toxins can mess with some of these different enzymes that run the pathways, such as BPA out of plastics interfering with methyltransferases. Well, there are dozens and dozens of methyltransferases in the body. We're also looking at phthalates and parabens in that way. The research is just now beginning to erupt with how bad glyphosates are for our metabolic pathways. And my suspicion is that we're dealing with those types of issues when we see something out of the ordinary, such as fructose sensitivity being abnormal, yet the glucose-insulin interaction is okay. Glucose-insulin is very dependent upon chromium, but that fructose sensitivity can be impacted by more than just the sugar that is in the diet. It can also be impacted by if enzymes just get shut down. So now, going on to the next question. Does CoQ10 help in the electron transport chain with people who have mitochondrial SNPs? It absolutely can, and here is why. CoQ10 is needed, I think it's between complex 2 and complex 3 of the electron transport chain. Let me review the physiology of the electron transport chain. There are 5 complexes: complex 1, complex 2, complex 3 is what we think is coenzyme Q10, then complex 4 and complex 5, out of which comes ATP production or energy production. Well, if someone is having some mitochondrial SNPs, say in the NDUF, the NDUFs, which are part of complex 1, by giving CoQ10 is a required factor further down in the electron transport chain. There are some SNPs that I've seen on genetic reports in the COX-1 and COX-2 area, and that is complex 2. So again, by giving CoQ10, you can still get some benefit even if you have mitochondrial SNPs on a report. Here's the other very important factor to remember. Just because a mitochondrial SNP is abnormal on a report does not mean that it is genetically expressed. So what that means is that you may have an abnormality on a report, but if the needs of the body have not overwhelmed the capacity of that enzyme to work, then it's not being expressed. If an enzyme is homozygous, for example, if someone is homozygous for a SNP, if your body, we think a homozygous SNP is only going to be working at approximately 40% capacity at the most. But if your body only needs it to be working at approximately 30%, then that particular enzyme has never been expressed. And so it really doesn't make a difference that enzyme is mutated. It's only if it actually becomes expressed. So here we have another question actually about this test and how accurate this test is, where it was developed, how it's run. the research, et cetera. So let me just say some general comments about that. This particular test, the micronutrient test, was developed at the University of Texas in Austin, Texas, about 20 years ago. So the company has been accumulating data and test results over the last 20 years and have well over 10,000 to 15,000 samples in their database. And within the predictable reliability of laboratory values, the margin of error has always been consistently less than 8 to 9%, which is less than the margin of error that we see with the standard labs in the market that we would see through hospital labs or Quest Diagnostics, for example, or LabCorp example. The industry standard is that lab-to-lab variability is between anywhere from 8 to 12%, and this micronutrient test has always beat that. So the research is pretty solid with this, and it has been verified repeatedly by clinicians that have blinded the test result. And in any clinicians that would be interested in that, I would surely direct them to the Director of Laboratory Services at SpectraCell, who could go over the finesse points of the reliability, research, documentation, and background of this particular test. So here's our next question. What test would I recommend for someone with a non-healing leaky gut, thyroid issues, and arthritis issues? Well, if someone has an inflamed GI tract and thyroid, immediately we always think about our antibodies being formed against the thyroid, could potentially antibodies being formed in the joint mucosa causing an inflammatory arthritis. And for that, we're thinking about the gap junctions in the GI tract. This particular company does not have a test that tests specifically for a leaky GI tract. There are other companies in the market that can test different analytes that are known, are thought to assess that. And I would just steer you toward looking for companies and that would test for zonulin and lipopolysaccharide A. At this time, SpectraCell does not test for these two analytes. That's not to say that they won't in the future, but at this point in time, it's not available through SpectraCell. But if you do have a leaky GI tract, there is massive anecdotal stories, documentation, some research that would suggest that a leaky GI tract will lead to increased antibody production, autoimmune type status, and then the body just sort of picks where it wants to start attacking itself as the autoimmune process. For some people, it's thyroid. I was at a conference over the weekend where a couple of papers were being presented where it was suggested that Candida in the GI tract was a potential cause for an inflammatory arthritis. And when we cleaned up when the patient cleaned up the Candida, the inflammatory arthritis disappeared. So we have to be thinking about, is there a leaky GI tract? And if there is, what we know is that is a prime opportunity for abnormal pathogens to come in, because a leaky GI tract is known to be an inflamed GI tract. And when that happens, then abnormal pathogens can come in, particularly if we do not have sufficient probiotics giving the first line of defense. So here's the next question that I have here.
Any reason not to take glutathione and vitamin C at the same time? I don't know that there is. I've not read that. I don't know that. I know that I take mine every day at the same time. I take liposomal glutathione and vitamin C. Vitamin C is known to help recirculate glutathione. It also, glutathione recirculation needs some lipoic acid and some vitamin E. So when thinking about glutathione, I do think about whether there's enough alpha lipoic acid and vitamin E when I'm looking at a micronutrient report. But I don't know of any particular reason why you couldn't take them both together. The one thing that I would suggest, however, is that when taking vitamin C, it's just good to remember that vitamin C only hangs around in the GI tract in the body about 3 to 4 hours. It is a water-soluble vitamin, and you must have, in order for levels to be really good, you must take some vitamin C at least twice a day. And it's the least expensive antioxidant on the market that is so widely available. And so you could take some vitamin C every 3 to 4 hours, and that would help the vitamin C levels. I would just encourage you, though, to be cautious with the vitamin C and choosing what kind you take based on background health problems. And what I mean by that is that some ascorbic acid is made from corn. And if you happen to be sensitive to corn, then you really do not want ascorbic acid from corn. If you're sensitive to histamine, on the other hand, you do not want vitamin C from a citrus base. Then ascorbic acid would be appropriate. So that just some things to be considering about vitamin C. So here we have a question about asparagine, and frequently levels are good in other amino acids, but asparagine can be low. Asparagine can be low in the face of other amino acids being nice and normal, purely from the perspective that asparagine, for some reason or the other, is not being made appropriately. Asparagine is a non-essential amino acid. And so what that means is that it's made from aspartic acid and glutamic acid, I think it is. But you have to have those enzymes working. If the enzymes are working, but you don't have the cofactors, we still won't get the end product. And any of those variables can be problematic with making a downline product such as asparagine. If you don't have enough aspartate upline, or if you don't have enough glutamate upline, if you don't have enzymes that are working and that may be shut down by environmental toxins, such as arsenic, lead, or BPA, for example, which we know can shut down a lot of enzymes, or cofactors. You may not have enough zinc if that is a cofactor for that particular enzyme. So there are many variables that will determine how much an end product is going to be made. So here's our next question. If B6 is low, how much and how long until it improves? Is there a way to know if it is improving without retesting? Well, I always say, the proof is in the pudding. And when you look at the biochemical pathways and you assess where vitamin B6 is impaired, if you look at some of those interactions, and one right off the bat that I know of is vital, you have to have vitamin B6 to run the transsulfuration pathway. It is a dependent enzyme for that. And so if you start to replace vitamin B6, what you should be seeing are some interesting changes in the way you feel. And the transsulfuration pathway is just one particular example that I'm talking about. If you are going to be replacing vitamin B6, one of the possibilities is that we have to keep in mind is there is an enzyme that metabolizes vitamin B6 to its downstream metabolite, P5P, pyridoxal 5-phosphate, for example. And if that particular enzyme, again, I know I'm talking a lot about enzymes, it's because enzymes are what run all the metabolic pathways of where these micronutrients are needed. So vitamin B6 is one of those that can help run some of these different pathways. But there is an enzyme that metabolizes vitamin B6 to P5P. And if someone is low, I would suggest searching for a product that is a combination product of vitamin B6 and P5P. But I would always start low. There are some individuals in the that suggest in the medical literature to be really cautious in giving vitamin B6. And I know in my residency and fellowship, I was taught not to give vitamin B6 more than 50 milligrams. However, we do know that in some individuals, select individuals, such as an individual that has pyruria, for example, may end up urinating out their B6. And in those particular individuals, they need very healthy amounts of B6. So you may give 25 milligrams of vitamin B6 and plus an additional combination of the P5P, and watch for changes in behavior, because that pyruria is associated with some emotional problems as well, and replacing that B6 can be very helpful, as well as zinc. Those individuals with pyruria tend to urinate out a lot of zinc. I would always recheck, and for someone with vitamin B6, I do check periodically a serum B6 in order to just keep track of that, because the suggestion is if you go really high, like over 200 or 300 milligrams of B6, that can precipitate a B6 neuropathy, which is reversible when you stop the B6. It has been documented in the literature. So we just want to be careful in that respect. Okay, here's a question. I'll read it. If a person comes back deficient in calcium but consumes plenty of dietary and supplementary calcium, how could this be the case? This patient has osteopenia at 30 years, I guess 30 years of age, and her D3, K2, and magnesium levels come back normal. Immediately that raises a red flag to me. Again, if you have an otherwise healthy individual, young lady, 30 to 40 years old, that is osteopenic already, low calcium, but high the other indicators, magnesium, K2, and D3, what should we be thinking about? Immediately, I would be thinking about acidosis. What is pushing an acidotic state in her body such that her body is naturally consuming her calcium in order to buffer the acidemia and pulling that calcium from the bones? We also want to be thinking about parathyroid hormone and checking that to see if maybe there is a hyperparathyroid etiology that could be causing some of this as well. But 9 times out of 10, when I see a situation like this, it's usually due to candida overload in the GI tract that sets up and abnormal pathogens and much more of an acidotic state. But again, just remember, an acidotic state can be formed strictly by eating the wrong foods. If we're eating animal proteins without enough leafy green alkaline foods to balance the pH, we can become acidotic. If someone is an extreme athlete where they have a lot of lactic acidosis being built up in their muscles and not getting enough hydration and drinking a lot to thoroughly perfuse and hydrate these cells that have such acidosis, then the body is naturally going to pull calcium from the bones to help buffer that. It's a compensatory mechanism, and so we want to, be watching for that. The other thing, when I'm seeing anyone with osteopenia and trying to slow down that process of bone loss, I'm always looking at some of the other trace minerals also, making sure that they have enough boron, perhaps, and that it's not tested on the micronutrient test, at least not yet, but it may be one day. And the literature also suggests that silica could also be helpful, and there are some studies that suggest that a small amount of strontium is also needed for making good bones. So those are just some things to be considering, but by far in a 30-year-old, be thinking about is there an acidotic situation underlying the process, and then what is causing that acidosis, and investigate that more thoroughly. Okay, here's a question about buffered vitamin C versus ascorbic acid. I was told never to recommend ascorbic acid. Well, typically the main reason that people would say never recommend ascorbic acid is, as I said, is that it is made from corn. And so much of our corn is GMO corn, and many, many individuals are sensitive to ascorbic acid. So that is a consideration. But at the same time, a buffered vitamin C, if it is being made from a bioflavonoid citrus, what I had just mentioned before, is to keep in mind that citrus can trigger off histamine, and so it would be something worth thinking about. So here's a question. I had a client with a micronutrient panel who yielded rock star results, almost everything in the green and sufficient, and had only one deficiency. The amino acid serine was well in the red. She also had lower B1, B2, B3, B6 fingerprints. Can you explain this anomaly? Well, the very first thing that I would suggest when I see B1, B2, B3, and B6, when all of the Bs are not stellar where we want to see them, then I think about what's going on in the GI tract. First of all, are they taking a nutritional supplement that contains these? That's my very first question. My second question, if they are taking them, are they being absorbed? And when I see this many of the Bs all lower than what I'd like to see them, then that's what I'm thinking about, is what is inhibiting absorption of these Bs. And it's not uncommon that you may have an abnormal intestinal pathogen such as Blastocystis hominis. Blastocystis, or mycoplasma in the gut, are nasty little critters, and they can absorb your nutrients. It's not just Helicobacter, and it's not just Candida. There are frequently many other things that can cause some of these amino acids. Now, specifically about serine, why would serine be so low if everything else was doing well? Well, that would immediately suggest to me that perhaps, again, getting back to genetics and why I love looking at them, is that this particular person may have an SHMT genetic mutation. The SHMT enzyme is the enzyme that converts serine to glycine and back and forth. And if someone is heterozygous or homozygous in that particular enzyme, it can be absorbing that serine. And serine is, if it is needed to go to glycine, but it can't get back to reconvert it back and forth. It well could be a genetic mutation in that particular individual. Also, the other thing that I would think about is phosphatidylserine is a very important nutrient for lipid membranes. It's one of the constituents. We know that phosphatidylcholine is an important lipid constituent, and so I look at choline for those. But so is serine, phosphatidylserine. And one of the things that phosphatidylserine does is, or that it can do if you gave it as a supplement, we know this, it can blunt down cortisol. And so the question that I would have is there something in this person pushing cortisol up, such that serine is being pulled? So those are a couple of different reasons why I would see a really low serine. It could be a genetic enzyme defect, or what she is getting is being used up. Or it could be that this is a signature that her lipid membranes are getting into trouble and need some attention. Okay, next question. These are all great questions, by the way, everyone. Thank you. Thank you for providing them. How much lithium orotate would I recommend to help B12 into the cell? If you would listen to the webinar by Dr. Amy Yasko, and it's called The Lithium Connection, most of her work was done with children less than age 5 that were autistic. And she would direct patients to open up a capsule, a 5 milligram capsule for a toddler, and sprinkle some out once a day, like maybe a fourth of the capsule. In my practice, I use 5 milligrams of lithium orotate once a day in order to replenish those lithium stores for about 2 weeks. And then I encourage patients, they can continue it once a day, or they can decrease it to 5 milligrams twice a week. Again, approximating the nutritional value of what I would expect to see from tomatoes and potatoes. So, okay, here's a question back also about B12, and it is I'll just read the question. I have a 2-part question about cyanocobalamin. Why am I against using it, besides it not being able to methylate? And then the second question is, the patient told me it's natural in food, which is true, but why is it a problem in supplement versus food? Okay, so the reason I'm against cyanocobalamin, particularly when it is a synthetic and not coming from our food source, is that it is well documented that the cyano, which is cyanide, can block the electron transport chain. And when my patients are struggling for energy, I don't want even a little bit of cyanide coming in and blocking the electron transport chain. What is natural in foods as a food source, I'm okay with, but I'm not okay with opening up a cheap bottle of nutritional supplements that has cyanocobalamin written on it. But let me just explain and why that is. Cyanocobalamin is the original B12 that was discovered and made available across the counter. And what we now know is that the metabolically active B12 in the body is hydroxy B12, methyl B12, and adeno B12. It is not cyano B12. If you give somebody cyano B12, that cyanide has to be chopped off, dropped off, and the cobalamin has to pick up a hydroxyl group or a methyl group. If it picks up a methyl group, it could go into the methionine pathway. If it picks up a hydroxyl group, it can go on to possibly become adeno B12 going into the mitochondria. But that cyanide molecule has no use in the body, and when they get when it's brought into the body in a synthetic form, the suggestion in the literature is that it contributes to shut down the electron transport chain. That's why I'm so against it. When you look at the metabolic pathways, you don't see cyanocobalamin doing anything. It's methylcobalamin and hydroxycobalamin. And we have such a confluence of factors that are causing chronic fatigue syndrome and fibromyalgia that I just want to remove every impediment to try to get my patients as healthy as possible. So when I'm looking at what type of B12 to give an individual, the question that I ask always in terms of discerning the type of B12 is there are two questions I ask. One is, do you have anxiety? Do you have fatigue? If they have episodes of anxiety and agitation, then I do not give methyl B12. And particularly if on a genetic report their COMT enzyme is mutated. Again, I would reference Dr. Yasko's work it's available free of charge on the web. She has lots of webinars talking about her research. But if you gave a nutritional supplement with methyl B12 to an individual that has underlying anxiety issues, it can precipitate worse episodes of anxiety or panic. So in that particular individual, I would choose hydroxy B12. And there are nutritional supplements that will give plain methyl. There are others that would give a combination hydroxy and adeno. So those are the discerning questions. If someone has overwhelming fatigue and cannot get out of bed and there's no anxiety, then I would give maybe a combination of methyl B12 and some adeno B12. Those are the important considerations for B12 because you do not want methyl trapping, which can cause a lot of irritation, agitation, and distress. Okay, so here's another question. Repeat my recommendations of what to look for when weight loss is just not happening. There are a couple of reasons I think that weight loss may be impaired. One is if the formation of ATP, energy production, from your lipids or your carbohydrates are not going smoothly. And again, here are the nutrients that you need for energy production and the electron transport chain to be working well. You first of all have to have biotin. You have to have biotin. The second nutritional supplement outside of the citric acid cycle would be pantothenic acid. Pantothenic acid, pantothenate, contributes to making coenzyme A, which feeds into the citric acid cycle. So those two are our beginner two nutrients. But for lipid metabolism, you have to have adequate carnitine and magnesium. And I use acetyl L-carnitine. It typically comes 500 milligrams, and I would encourage acetyl-L-carnitine at least once a day, if not twice a day, to help with lipid metabolism. To help with carbohydrate metabolism, you have to have adequate alpha-lipoic acid. Lipoic acid is needed, as well as thiamine, riboflavin, and niacin. You have to have those three. And then for metabolism of your proteins, you need zinc and adequate oxygen, which if someone is breathing and aerating pretty well and getting some exercise, hopefully there's good oxygen exchange and there'd be enough oxygen there. So I hope that is also helpful. Here's another question. If a person has a heterozygous C677T MTHFR mutation, but on the micronutrient test has a good intracellular folate level, should she supplement with methylated folate? Could there be any harm with supplementing with 1 milligram per day of methylated folate regardless? So in this situation, what has been identified is that there is a heterozygous mutation for MTHFR. What this is going to mean is that the amount of methylfolate that is available for the methionine pathway is inhibited. But this is only a problem if that enzyme has been expressed. If the enzyme has not been expressed, then the folate on the micronutrient test could reflect really nice, good intracellular stores, and what she's getting from her diet is sufficient. The second part of this question is, would there be harm? There is not harm from supplementing low-dose methylfolate, particularly if we did it in divided doses like 400 or 500 micrograms twice a day. I would not see harm in that. Where we get into some discussion about how much methylfolate to give is actually the question, how many methyl groups to give? Because too many methyl groups can lead to something leading to too many methyl groups to a condition known as methyl trapping. And methyl trapping can become quite problematic and agitating. And there are some researchers that suggest that if you have an individual who you think may have methyl trapping leading to agitation, taking a little bit of niacin can soak up those methyl groups nicely and calm down some agitation. Okay, so the next question, we're getting back to an asparagine question. Can aspartic acid supplements increase asparagine level? I'm not sure. I don't know. I've not tried that in individuals, and I don't know the research on that. Here's another question. Is there a problem giving glutamine dosing? Oh, my goodness, 2 to 5 grams twice or 3 times a day for a compound heterozygous MTHFR patient? Yes, there's a big problem with that. The second part of the question is, I was told by a clinician these will convert glutamine to glutamic acid, which is excitatory. That is exactly the fear. Now, let me just talk a little bit about glutamine. Glutamine is an amino acid. It is the most common amino acid in animal protein. So if we're eating animal proteins, individuals should be getting world's plenty of glutamine in their diet. However, it's also frequently thought that if you have a leaky GI tract, you should pour on the glutamine in order to help that leaky GI tract. And for some people, that can be helpful. But here is the caution and the problem. And it's not so much that having a heterozygous MTHFR patient where this is a problem. The problem is if you give glutamine and it becomes glutamate, glutamate will build up in the body unless the GAD enzyme is up, running, and working really well. If the GAD enzyme is mutated from birth, genetic mutation, and or there are other toxins shutting down the GAD enzyme, such as lead, aluminum, and mercury, or too many sulfites coming through the transsulfuration pathway, shutting down the GAD enzyme, that glutamine, when it becomes glutamate, gets stuck in glutamate, and glutamate is extremely excitatory, and it can push up norepinephrine, which will lead to anxiety. It can increase nerve activation. It can increase microglial nerve ending. Glutamate is a very problematic compound in the body if it cannot be easily converted by the GAD enzyme. And, as we think about the pathways, glutamine becomes glutamate, and if all is well, glutamate should become GABA. GABA is the neurotransmitter for calmness, rest, and sleep. And if the glutamate gets stuck, however, that door is closed, you can't make GABA, and the glutamate is excitotoxic, and it's very, very problematic. So here's our next question. With a vitamin E deficiency in the test, what would I use and supplement? I do see vitamin E low from time to time, and as I mentioned earlier, it is needed to help recirculate our glutathione. I would give a mixed tocopherol vitamin E. And when you look for vitamin E, and what I mean by mixed is that there are multiple varieties of vitamin E. There's delta, gamma, beta, and one more. It's names that escapes me. There are 4 vitamin E's. And what you want is you want a combination of those vitamin E's. And so when you're looking for a supplement of vitamin E, just make sure that it's a mixed alpha, beta, gamma, delta. That's what it is. Mixed tocopherol. And the other consideration I would just put out there for consideration is that the base of the vitamin E frequently is in soy. Many, many, many women are very sensitive to soy. In addition, soybeans that are being used in these nutritional supplements frequently, especially ones that are over-the-counter and generic, are being synthesized from soy that has been soaked in hexane to be metabolized. And hexane can build up in the body as a toxin and can destroy the myelin sheath. So I would just encourage you to be discerning when you're choosing the vitamin E. And I'm not allowed to list name brands here, but I will tell you, if you search on Amazon.com or some of the online health food stores, there is a vitamin E that is based in olive oil. And I can't say the name of it, but it's sitting in my refrigerator. It's the one that I take, and it is easily accessible if you look for it. It's a vitamin E mixed tocopherols based in olive oil. Okay, so then, and here I think we're getting close to the end of our hour. Last question. How effective are food-based supplements for replenishing deficiencies? I have noticed the amounts are much lower then the recommendations on the report. Well, I'm okay with food-based supplements to a point, but where I have a little bit of heartburn with them is typically those food-based supplements are equivalent to eating lots of leafy green vegetables, etc., that you would get from the periphery of a grocery store. And both of those situations are assuming that we have perfect genetics. And as we all know, perfect genetics are just not seen. And there are, most individuals will have some genetics that are being expressed, and for many of those, we can circumvent them if we know what they are. For example, what I was talking about with the B12, of the different types of B12 that you can obtain in a nutritional supplement. And I would just make another plea to use really good nutritional supplements. I was at meetings this last weekend where a clinician spoke that he has had individually tested from a laboratory in Sweden 140 different nutritional supplements, and that were made primarily generic-based, and that demonstrated excessively high levels of cadmium and heavy metals. And what we think is that the cheaper the nutritional supplement, we get what we pay for, and there's just a lot of inert ingredients that can also be toxic to the body. So good quality nutritional supplements. And if you don't have perfect genetics, a food-based supplement may be inadequate. It might be fine if an enzyme has not been expressed, but if an enzyme has been expressed, then a food-based nutritional supplement may not have everything that we need. For example, if MTHFR has been expressed, we need nutritional supplements that give methylfolate rather than just depending on folic acid from leafy green vegetables. So the note that I have here is that we're at the end of our hour, and I just want to say thank you. The questions were excellent, and it's been a pleasure. I hope that this has answered individuals' questions, and I hope we can do it again.
Thank you, Dr. Zenker, for your expertise. We are out of more time for questions. We sincerely hope you enjoyed this webinar. Be sure to email us at webinar@spectracell.com to request future topics. Thank you for joining us, and good night.